Thank you, Pune Shoulder Course. Thank you, Nilesh and Sirish. I will try and make it as simple as possible. Forgive me, the more experienced surgeons who are sitting in the front row. The organizers did instruct me that make it very basic, which is useful to the younger crowd. So that's how it's going to be. Now, clinical examination. If you ask me what is the secret of my shoulder practice of last 25 years, it is clinical evaluation. Clinical examination is a combination of art and science. And the decision making, whether to operate, not operate, if operate, then what surgery to do, I think is the secret, which is based not on MRI, not on CT scan, but simple clinical evaluation. And the most important thing is when not to operate is also based on clinical examination. In fact, Sirish just showed a slide of some rotator cuff pathology with some capsular tear inferiorly. And he said that I ignored it because there was no clinical relevance. So that is exactly exemplifying what I'm saying. Now, a shoulder is a very unique joint, as we all know. It is one of the most mobile joints in the human body, and therefore it is most disabling. We often see so many knee and hip problems and the patients want to live with it. But a shoulder problem, they want something done. And the best part is that the shoulder joint is unique because it lends itself for clinical examination. Almost 90% plus conditions of the shoulder can be diagnosed with consistency and accuracy by simple clinical examination. And if you can accurately diagnose, you can treat successfully. So that's how important it is. Now we all know, we all have a consensus that majority of painful, stiff shoulders are not real frozen shoulders. They are something else, which we will talk about. So now the first and the foremost thing in clinical examination, if any registrar or a fellow calls me that I have a patient, first thing I want to know is the age of the patient. So if you understand how age has implication, then there is a running list in my mind. If the patient is young, then I know that it's a mechanical kind of problem. If the patient is in the so-called elderly age group, then they are degenerative conditions, which I list. And therefore, the symptomatology also will be accordingly. In the young, mechanical symptoms, you have typical like ACL or a meniscal tear, you have clicking and popping and the shoulder giving way or a dead arm. Whereas in the more than 40, the two commonest symptoms they will present is pain and stiffness, which leads effectively to a disabled shoulder. So painful, stiff shoulder is the commonest symptom that you're going to come across. Now we all know that what frozen shoulder is. It is a capsular fibroplasia, and there is again a consensus on that. And how do we first eliminate when you examine that this is not a true frozen shoulder? It is uncommon. It's seen in about 10% of cases. And here is the internationally accepted definition of a true frozen shoulder, that you have a painful stiff shoulder without any underlying etiology which is identifiable. And typically it is the external rotation which is not only restricted but very painful, and there is an abrupt bony-like stop when you externally rotate. So it's the most affected movement in a true frozen shoulder. There is a bony block-like effect when you externally rotate, passively standing behind the patient, and it's extremely painful. And it's more often seen in diabetic people. And those more than 40 age group, the large bulk, 90% of these painful stiff shoulders are a list of degenerative conditions. So this list should roll out in your mind when you are in a busy OPD. And it's very easy. You don't have to memorize this list. Just think of every anatomic structure around the shoulder and you create a degeneration. For example, AC joint, then you have AC joint arthritis, which leads to a painful shoulder. Then you have a glenohumeral joint, you create a degenerative condition. Then you have glenohumeral osteoarthritis, rotator cuff, degeneration within the rotator cuff. So you have tendonitis or a partial tear or a full thickness tear. So think of the structures and a degenerative condition affecting that structure, and you have the list. So if it is so simple, then what is the big deal? The key is a lot of these conditions present with some amount of capsulitis. And that's where the problem is, that the old teaching, moment you see, say, a rotator cuff tendonitis with some amount of capsulitis, you end up labeling it as frozen shoulder, which is not the case. The tip I can give you is, that this secondary capsulitis, how to differentiate from a true frozen shoulder, the secondary capsulitis usually is starting and affecting the posterior capsule. So you will see a lot of times cuff disease patients with inability to go behind because of the posterior capsulitis. And if left unattended, this process of capsulitis can then start affecting the rest of the capsule, and then you have a real diagnostic dilemma. But when you have a good, reasonable forward elevation, patient is in the 40+ age group, you are suspecting a rotator cuff disease, and they have posterior capsulitis, then that is not a real, true frozen shoulder, because their external rotation will not be behaving like I just explained as in a true frozen shoulder. Impingement or rotator cuff disease, now there are a battery of tests. So let me be honest, I don't do all these tests. I do only 2 or 3 tests, which I'm going to demonstrate on a live patient that Shirish has brought. Which ones I like, I'm going to show you. The one in green is the one I prefer, the Job test or empty can test, whatever you want to call it. The rotator cuff power assessment I'm going to demonstrate. And of course, the most fruitful is an injection test, which is therapeutic as well as diagnostic by injecting in the affected zone. So if you're suspecting a cuff disease, you will inject in the subacromial space. If you're suspecting an AC joint problem, then you will inject in the AC joint. So these are representative slides of how to test power in the supraspinatus. Sorry about that. Then this is a classic video of a hornblower sign, which is showing you that the infra is gone. In order to externally rotate, with the arm adducted, he is unable to externally rotate, but if he abducts his arm, he is able to externally rotate. This is a full thickness tear in the infraspinatus. He is externally rotating using his teres. So he abducts and externally rotates. So this is how you do Didier-Paté sign, where you check for the teres power, which again I'll show you. And then for subscap, of course, we all know the lift-off test, but often the patients are having posterior capsulitis. You can't internally rotate enough to execute the Gerber sign, and then you have the belly press and the Napoleon, which again I will demonstrate on the patient. And lastly, you can have a massive full-thickness tear and you have a drop arm sign. Acromioclavicular signs, very simple. The most reliable one is local tenderness, very easy. Patient actually points that it's painful on the AC joint, and if you compress the AC joint, and then you can do further indirect compression by a horizontal and vertical compression test. Osteoarthritis, the giveaway is you can sometimes, if the X-ray is not available, misdiagnose an osteoarthritis as a frozen shoulder if there is no X-ray. But the key is that the age, often it is bilateral and it is painful stiff, and you can often get crepitations when you examine the patient. And then, of course, once you see the X-ray or MRI, you have a clear idea. Less than 40 is the unstable group. Now, instability, anterior dislocation is the common one, as we all know. A patient gives the diagnosis. So there is no big mystery about clinical evaluation. What I am going to really examine is the quality of his collagen, the quality of his ligament. If I can predict what will be the capsule like by clinical examination. And therefore, to me, in an unstable patient, the key is assessing generalized ligament laxity. The key is assessing the Walsh sign, because that helps me plan the line of treatment and interrogate and explain to the patient what are the surgical options that he may have to undergo. Posterior instability, previous speaker has already shown some signs. The one I like is the posterior apprehension and the jerk test. These are the ones I find more useful than the others, but a high index of suspicion is the key, collaborated with the MRI findings. Slap tear, again the key is high index of suspicion, and of course you have some tests which are not really very accurate or reliable. One or two slides, some situations in the shoulder, some conditions in the shoulder have a very unique presentation. One of them is, as you all know, acute calcific tendinitis. When a patient presents with pyogenic arthritis of the shoulder-like presentation, very inflamed, red, extremely painful, without any trauma or any other symptoms, you must think of calcific tendinitis. Of course, these calcifications can present in a chronic form as well. and some uncommon conditions as you see here, such as synovial chondromatosis, avascular necrosis. What you see here on the right is a brown tumor in hyperparathyroidism. So you must keep in mind these uncommon conditions. And must examine, I cannot emphasize more, the patient's scapula, looking for two things. One is wasting of the supra and infra spinous fossa, and dyskinesia of the capsule. And lastly, do not forget that there is a human being attached to the shoulder. It's not the shoulder which is attached to the human being. There can be pain coming from the subdiaphragmatic organs. There can be cervical spine pain going into the shoulder and many other conditions. Lastly, I love to say this, I'm not an arthroscopist because I cannot see pain through the arthroscope. Now we'll have the patient on the dais and we will I will do exactly as I do in my clinical practice, a clinical examination. And then we can have open question answers. Do I have a collar mic or something? Yeah. कुठून आले तुम्ही? फार दूर न आले? हां, खूप 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 आभार आमच्यासाठी तुम्ही आले. हां, काय त्रास काय आहे तुमचा? मी डॉक्टर देसाई, संजय देसाई, मुंबईवरून आलो. कॅन यू गिव्ह केव्हा पडले होते? So for those who do not understand Marathi, he fell on 11th of Jan. कसे पडले?
असं चालता चालता पाय घसरून पडलो.
आणि हातावर पडले का कसे पडले?
नाही, हात असा खिशामध्ये होता.
हो.
असा पाय घसरला वाळूच्या खाड्यावरून. ते असं पडलो, ते हात असा वरती झाला. ते इथं असं कडकडकड आवाज आला.
आणि तुमची वय किती?
44.
हा, 44 वय आहेत ना. आणि जेवण वगैरे कुठल्या हाताने करतात?
हे हाताने करतो.
So he is a 44-year-old male. He is right-handed. He had a fall on the 11th of Jan. His hand was in his pocket and he fell on the tip of his elbow. आणि ते पडायच्या आधी काय दुखत नव्हतं ना?
काय नाही, काय नाही.
जसा हा हात आहे तसा होता.
तसंच सेम.
He was asymptomatic before the fall. आता ते जानेवारीला आता 1.5 महिने झाले ना पडून. तर आता त्रास काय?
इथं फक्त दुखतं आणि हात असा वरती होत नाही.
अच्छा. आणि आधी फुल जात होता?
आधी फुल जात होता. 11 जानेवारीच्या अगोदर फुल जात होता.
एकदम चकाचक होता?
हो हो.
अच्छा. आणि कुठे दुखतं? बोटो लावा तिथे.
इथे
खाली इथे पसरतो का?
कधीतरी
कधीतरी पसरतो. आता असं तुम्ही माझ्या समोर असे उभे राहा आणि दोन्ही हात असे समोर ठेवा. चांगला हात वर घ्या फुल. ह्याच्यात काय त्रास? आता हा घ्या. नाही जाणार?
नाही.
हा, आता दुसऱ्या हाताने झाकला त्याला आणि दुखलं की सांगा. दुखत नाही ना? ओके. सो नाव खाली ठेवा आणि असं हात सोडलं तर पडणार का? ओके. सो 2-3 things without touching him I want to tell you. So one, I have already got my list in my mind. He is 45, 44, asymptomatic, before had a fall. एक खांदा सटकला नाही ना? नाही. So no dislocation. So I'm already suspecting that it's a rotator cuff problem. Probably a full thickness tear in the rotator cuff. How do I rule out? Even frozen shoulder will go only up to 90 and won't go up. But passively he is able to go up almost full and he says he has no pain. So that tells me already in my mind that he is less likely to have a frozen shoulder. He is more of a cuff problem, cuff related problem. And now we will try and see if I can judge the size of the cuff tear by clinical examination. Give me the radiologist sitting here. So असे उभे राहा आणि असं ठेवा आणि वर उचलायचं. तुम्ही खाली नाही सोडायचं. मी धक्का देणार. असा वर ठेवा. जेवढा जोर आहे तेवढा. नाही होत. सो सुप्रास्पायनेटस इज व्हेरी वीक. नाव दोन्ही कोणी असे चिपकवून ठेवा आणि मी बाहेर सांगेल तेव्हा असं धकला. आत असं धकला बाहेर. सो आय फील दॅट द external rotation power is also weak, not as much as supra but is certainly weak. So supra is almost 2/5, infra is like 2 plus or 3. So I have in my mind he is likely to have a supra plus infra. Let's check the subscap. हे उघडा तुम्ही पहिला फिरून जावा. हा जो चांगला हात आहे इथे लावा आणि मी सांगेल धकला तेव्हा असं करायचं. हां धकला आता. So this is his normal asymptomatic side. The subscap is, how does the Gerber test, as you all know, the younger crowd, how does it function? What is the logic behind it? After you fully internally rotate the humerus, the shoulder joint, the only muscle which can rotate internally even further is subscap. So it's a highly specific test, but the problem is that a lot of times the patient have pain and you can't really execute that, but he is able to do it. Dhakla, Jorat, so he has good power. Suppose he was stiff posteriorly and I couldn't do that. हा चांगला हात आहे ना, हा हे इथे चिपकावून ठेवा. बोट हा दुखतो का? So Hawkins positive. See, he says it's paining when I do that. कुठे दुखतो असं केल्यावर? Yeah. So again, cuff disease. हे इथे लावायचं आणि दाबून ठेवा. असं बंद नका करू. हां ह्याला सोडा. दाबलं? So subscap is intact to me. So now, number one, 44-year-old, symptoms after the fall. He has a rotator cuff tear. It's involving the supraspinatus and the infraspinatus. Subscap is intact. The AC joint is asymptomatic. So the diagnosis to me is a full thickness cuff tear involving supra and infra. Now, this is how we've taken less than perhaps 2 or 3 minutes. You are reasonably accurate in your diagnosis. We will know in a minute. If there are MRIs, then we will see them. Before seeing the MRI, any questions from the audience?
Biceps.
Biceps, okay. Now, I did not look specifically for the biceps. Why? If the subscap is intact, my feeling is more or less biceps should be okay. There is a 33.6% incidence of biceps disease in full thickness cuff tear. I published it just in October issue. So 66% chance that the biceps may not be involved. असं ठेवा आणि हात उघडून ठेवा. वर उचला. ह्याच्यात काय दुखतो का? Okay. So he has some symptoms along the biceps. We will keep that in mind. That will be on scopy if the biceps is affected, whether to do a tenodesis or a tenotomy. Anything else the audience would do more? Of course, I'm presuming I've checked the cervical spine also. I've asked about any subdiaphragmatic organ problems. काही liver वगैरेचा काय problem नाही आहे ना?
So can we differentiate between a full thickness cuff tear or a partial cuff tear on a clinical examination? So full thickness cuff tear from a partial cuff tear on a clinical examination.
Yeah, I think, see, it's the whole package. If you have a history of trauma, if you have a drop arm sign, and on examination the power is 2, then very, very high chance that it won't be a partial tear.
Okay.
Partial tear usually is affecting one tendon. It's very rare for me to see a partial tear of the supra and the infra. So moment I see that the power is weak in supra infra, drop arm, power is too low, full thickness. Otherwise, power is not bad. He is more painful rather than weak when I examine. Then I will think of a partial thickness tear. Does that answer your question?
Yes, sir.
Yeah.
Thank you, sir.
Dr. Desai, we have MRI. Can you
Yeah.
read it? I want you to read it now.
Okay, yes, of course. I love reading MRIs.
So,
Sorry, Anupama.
excuse me, sir.
We have limit 3 cuts only, which are relevant.
Yeah, 3 are more than enough. The rest of them, they anyway do it unnecessarily. So here it is, a full thickness tear in the rotator cuff. Nikam, इथे येता का? बसू शकता. I would also, just for not embarrassing him, I would have undressed his shirt and undergarments and examined his scapula. I would have looked for wasting and the dyskinesia of the scapula. I would have done that, but I won't be doing right now.
So my question was on that. So what's your routine test for scapular dyskinesia which you would actually follow in your clinical setting?
I would ask him to actively raise his arms with his back towards me. Okay. I would watch the actual rhythm of the scapula, compare it with the other side.
So but in any rotator cuff pathology, Usually we will expect some kind of dyskinesia.
Yes, so I'm going to correlate that. That little amount of dyskinesia or lack of rhythm in a cuff disease is expected. I'm not going to do anything about it. But I will keep in mind that I'll have to rehabilitate him better with that in mind. This is more relevant in young, unstable shoulders, especially voluntary or subluxations which are multidirectional, posterior. That group, I want to do a more detailed examination.
Okay.
So here is a full thickness rotator cuff tear. Now, again, I would scratch Anupama's brains that is this repairable? So if you look at the classification, this is retracted grade 2.
Okay.
Help me.
Early grade 3 because it's gone beyond the top of the humeral head.
So grade 3.
Yeah.
So therefore, to a radiologist, this is not repairable, right?
No, I haven't seen the muscle bellies.
Okay. You mean the Y cut?
Yes.
And tell us what would you want to look in that Y cut?
I want to see the size of the muscle belly and I want to see the degree of fatty infiltration into the muscle belly.
But will that make it not repairable or repairable?
See, if the fatty infiltration is more than 2 plus and if the belly is shrunken to maybe more than 50%, then perhaps it's not repairable.
Okay, so this is repairable?
Yes.
Okay.
Also, the cartilage is good, which you can't see clinically.
But
Cartilage is good.
Cartilage of the glenohumeral joint?
Yes. Yes.
But he is 44, I expect it to be good in any case.
Probably.
Yeah. Okay, now, so here is the eggshell cut, and here you see that the infra is also affected. There is a tear in the infra and a full thickness tear in the supra. There is some amount of fatty infiltration there. So now, clinically, we were fairly accurate. Sirish, would you grant that?
Yes, I perfectly agree.
And would our esteemed radiologist also agree? Yes, that we could diagnose a supra with infra. And are there any more cuts to be seen?
No, we have these 3 cuts.
Yeah, okay.
Yeah.
So any questions from the audience?
I think we can take a couple of questions and then we'll have to move on with video presentation.
Excuse me,
Of course, yeah.
So can we have a slap tear as a differential diagnosis?
A
in
slap
this case?
tear as a different for this patient?
Sir,
Why?
upon clinical examination.
No, a slap tear would not present with a drop arm.
Except for that, sir.
That is the key.
Restriction
Drop arm, once you have a drop arm, then you have a diagnosis in front of you. Unless it's a paralyzed shoulder for some other reason. But a slap will not present as a drop arm. The weakness in the supra will not be there in a slap tear. So no, slap does not come to my mind as a differential diagnosis. He could have a slap along with a cuff tear. That will be an arthroscopic finding. Very, very difficult in the presence of a cuff tear and a painful shoulder to clinically say that he has a slap.
Last question.
Sir, MRI shows that there is a partial thickness tear. So do you treat all partial thickness supraspinatus tear arthroscopically? Do you all repair it or it depends on clinical examination?
Most partial tears I conserve. One, those which I operate are often the bursal side deep tears because they are very aggressive in behavior. They are more painful. Partial tears deep 50% above on the bursal side, you can predict that they are more likely to remain symptomatic despite conservative treatment and will probably end up requiring surgery. However, my first choice will be conservative treatment even in those.